Absolutely. So we have a case discussion in where we're talking about what to do after failure to first-line treatment with immunotherapy, either IO with immunotherapy with Ipilimumab and Nivolumab, or TKI-IO combination. And we really have scarce data letting us know what to do after failure to these therapies. We have two different scenarios, the patients that have oligoprogression and the patients that have wildly metastatic disease on progression. So for oligoprogression, we need to address it's usually less than 5 sites that are progressing while the rest of the disease is controlled. We also need to acknowledge that these patients should not be having lesions on central nervous system, and also, that recently, the definitions for giving local therapy with SBRT or other radiation modality include that the lesions that are progressing are less than 30% of the total amount. And we know those patients can benefit from targeted therapies to local sites, but we also know patients with widely metastatic disease will need a switch of therapy. It's kind of easy to say that after Ipilimumab, Nivolumab, we should go to a TKI, mostly Cabozantinib, because we have the CaboPoint data, for example, and a lot of prospective and retrospective data suggesting that TKIs are worthy in that scenario. I think the decision is harder when you say, for example, after failure with Cabo-Nivo, Pembro, Axi, or Pembro Levantinib, then that's a little trickier, right? We have another TKI to follow. We do have Elsutifan data with benefit on progression-free survival, but not overall survival. And I think we all are concerned that, doublet therapy beyond progression, either the T-Nivo2 or the contact-free data were negative in doing combination therapy with IO-TKI upon progression in first line. So that's where we are. I think we should push patients to clinical trials, but in the meanwhile, that's the algorithm that we usually follow.